So abortion is a pregnancy that ends before 20 weeks. It's either spontaneously or you choose to. We have state laws about that, but take note, before 20 weeks, you can decide to take off your baby, or spontaneously, you'll get a miscarriage that will have the baby come out, and that is considered an abortion. Types of abortion, we have miscarriage. This one ends because of natural reasons. Induced is an elective reason for existing for terminating pregnancy. Elective is when you make up the choice. We have the threatened or the spotting one. You'll be spotting and you have cramps without any cervical changes. It's also a type of abortion. So you think you are pregnant, or you know you are already pregnant, and before you know, you start spotting, and then you end up losing the baby. Then we have the inevitable spotting and cramping that occurs and the cervix begin to dilate. The inevitable is the cervical dilation, when the cervix start opening for no reason. There is no specific cause to relate to that, but the cervix is not strong enough to stay intact as the pressure of the baby increases. Then we have complete, which is loss of all products of conception. Everything comes out and you lose everything. Then we have the missed abortion. This is product of conception that retained in the uterus. So you have the baby in your stomach, the baby is dead, or part of the body has come out, but some other pieces are retained in your uterus. So we have another complication is bleeding during pregnancy or implantation. And this one is bleeding that occurs to up to 14 days after you do your pregnancy test and you are positive. So you have your pregnancy test done and then you come back positive and within 14 days. So you check and you are pregnant today, and in 14 days you start having spotting. So usually this one lasts for 1 to 2 days and is lighter than a typical menstrual period. So this is plantational bleeding. So it's lighter than the normal bleeding. So it's possible that you can still keep that baby. That doesn't mean you are having a miscarriage or something, but sometimes there is called plantational bleeding. I know we know that one. Let's talk about risk factors. So the risk factors for people who get miscarriage or people who get abortion are those who have experienced a previous one. So if previously you've been pregnant and you keep trying and trying, you can get miscarriage. So we have advanced age, people who are older. So you are like 45 plus and you're trying to get pregnant, you'll be getting this, you are at risk for abortions. Intrauterine abnormalities such as adhesions or fibroids. We know this. Ladies with fibroid are at risk for abortions. And we have previous elective abortion. This one is optional, it's a choice that a person make. Then we have prolonged time to achieve the pregnancy. And then we have low serum progesterone. So if the lady doesn't have enough progesterone in their body, they cannot hold a pregnancy. So when you get pregnant, you will lose it. You are at risk. Polycystic ovarian syndrome. This is an abnormality. When you have a cyst on your ovaries, then you stand a risk of abortion or miscarriages. Then thyroid dysfunction, and those with thyroid issues, if a lady has thyroid issues because of the hormonal imbalances, because of the secretion of the thyroid hormone, it inhibits the egg from implanting in the uterus. So you can get abortions. You are at risk as well. Those with low body mass index, the tiny ones, those that don't have enough weight, they are at risk. Those who smoke, of course, smoking, alcohol, cocaine use, drugs, caffeine, too much caffeine, you're trying to get pregnant, you need to work on all those things. They can inhibit implantation, and they can cause miscarriage, or they can cause an abortion. Then assessment. So when a lady is having an abortion and you assess, what do you expect to see in a problem? Remember, I'm talking about conditions that are related in pregnancy, conditions in pregnancy that are problems. So the first one I tackle is abortions and then bleeding disorders. So that's what I'm talking about right now. So the NCLEX will present to you with the lady who has been bleeding, and they want to know which of these ladies are at highest risk for miscarriage, or which of these ladies are at highest risk for an abortion. Then they tell you the woman's age is 42 years. So if 42 years is there and 38 years is there, of course, 42 is at highest risk than 32 years. If a lady has fibroid, they will not intentionally put all these things. They can put a lady with fibroid, they can put maternal age, and they still add another complication to one of the answers that will make it more obvious that this particular one, she has fibroid. She was diagnosed of having a cyst on the ovaries years ago, but this one only has a maternal advanced age. So if somebody has fibroid and had ovarian cyst a couple of years ago, was diagnosed, you are not sure if you diagnose and the question don't tell you it was taken care of or they had managed it, that tells you that it's possible it's still there, because the cyst can still be there. And then they tell you, or the person has thyroid problems. Those things are more at risk. So even though all these things I mentioned are risk factors, but when you see them in a question, you want to be able to understand that some are more obvious than others. So if you talk of maternal age and previous elective abortion. So previously I decided to have an abortion. That doesn't put me at risk, but if I don't go back to choose, it's possible that I can keep a normal pregnancy without having challenges with it. So when you see a previous elective abortion, and then you see a lady who had previous miscarriage because they had thyroid problems, of course, the thyroid problems will take priority of causing an abortion than the one that electively or voluntarily opted to have an abortion done. So, or they talk about the lifestyle of the woman, the lifestyle. If the woman don't change, if the question is asking of lifestyle, you have to notice that anything that has to do with alcohol, no medication will want to go with any alcohol, or smoking, drug use, cocaine, and all those things. So let's talk about the assessment. You will see spontaneous vaginal bleeding. So far as there's miscarriage, blood will come out. Then low uterine cramping or contraction. So the lady will complain to you that I have cramps in my lower abdomen. So they'll present to you and say, I have abdominal pain. So you assess the quality of the pain, location of the pain, and you let them describe how is the pain like. I was making a video today earlier on, and I was explaining that when the patient say, I have pain, you have to ask them, what kind of pain is it? Don't give them suggestions. Don't say, oh, it's either sharp pain, dull pain, cramping pain, or what's the other thing? Pinching, or whatever you want to describe the kind of pain. Let them tell you. They'll tell you it's like somebody is pinching me with a knife. Sharp pain. So there will be pain, there will be blood clot and tissues that will come out of the vagina, and a woman can go into shock because she's bleeding. Let's look at the interventions. What are you supposed to do? Or what are you supposed to educate a mother? So you are answering the questions and they give you this. They're giving you a lady with frequent or past history of miscarriages and abortion. The lady is pregnant again and is back. And it's telling you, I have lower abdominal cramps, but no spotting or anything. But I'm just here because I'm scared. I had 3 miscarriages already. So you want to encourage them to maintain a bed rest. You want to get their vital signs. You want to monitor for the cramps and bleeding. Then you want to count the pads to evaluate blood loss and save the expelled tissue and clot. So if the lady is passing out clot and then you put the pad there, you want to save the pad, and then you want to get the clot too, so that it can all be examined. Is it a part of the baby? Then you maintain IV fluid and prescribe medication, and you want to monitor hemorrhage and shock. You want to monitor for severe bleeding and shock. Now let's talk about ROGAM. So ROGAM will be administered for women who are Rh negative. So if the woman is Rh negative, the woman will get ROGAM because you're having threatened abortion. at that point. The other time I was talking about ROGAM, and I said ROGAM is given at week 26 to, no, 20, yeah, 26 to 28 weeks. ROGAM is given to a woman who is Rh negative at 26 to 28 weeks. If the baby is Rh positive and the mother is Rh negative, at 28 weeks, the mother's body starts sensing the baby as a foreign object. So you will see a reaction, and there's possible miscarriage even at that age. So because of that, the woman will get ROGAM at 28 weeks, and then after delivery, she will still get ROGAM. But this happens with only the first pregnancy. So if I am pregnant for the first time and I am Rh negative and my husband is Rh positive, there is a possibility that the baby can be Rh positive from the father, or Rh negative, opposite of mine, from the father. So the woman is still going to be monitored and gets ROGAM at 28 weeks. So provide psychological support. Of course, you want to do this. Now let's talk about cardiac diseases. So a pregnant client with cardiac disease may be unable to physiologically cope with the pregnancy or with the added plasma volume. You know, when a lady is pregnant, there's increased blood supply. I think I mentioned this in our last class. There's increased blood volume, and the blood volume will peak at 32 to 34 weeks and then declines to week 40. So from 34 weeks, the blood volume starts declining. The whole body starts preparing for a different scenario of delivery instead of just trying to have the baby grow. So cardiac output is increased. There's volume, there's increased supply of blood. Like I had mentioned on the last, all the body organs are impacted. So everybody starts preparing for a change. So when you assess a patient who has cardiac problems and is pregnant, coping is a problem. So take note of coping mechanisms. So when you are educating that patient, you want to take note of what you tell her about their ability to cope with the present situation. Psychologically, that woman is kind of disturbed already. So you have congestive heart failure and you are pregnant. That means your heart will have to get more volumes of blood to be able to work. So you can imagine what is going to go through in a person's head. We are all humans, and you can imagine being told that you're already a hypertensive and you had a history of heart failure, or you had a history of a problem with your heart, CHF especially, and then now you are pregnant. It's going to be psychologically traumatizing. So you want to be supportive, and you want to take notes that blood volume increase 32 to 40 and start reducing around 40 weeks. So when you assess such a woman, you see cough and respiratory congestion. Normally, when a lady is pregnant and is getting to 34 weeks plus, you see that they are breathing. They can't do so much of activities. It's so heavy. So at that point, there's already a little short of breath with every little activity. But having a cardiac problem gives you a higher problem than before. So you have cough and respiratory congestion. You have dyspnea and fatigue. You get tired. Palpitations and tachycardia, peripheral edema. So it's in this case, it might not be, what's the name? What's the complication for pregnancy that I'm forgetting? It might not be preeclampsia. Yes, I'm sorry, I just remembered. It might not be preeclampsia that will give you the edema, but if you have an underlying cardiac problem, like I mentioned, CHF, you can have edema. You can have edema. So you can have swelling in your legs. That is not a sign of, even though that's an obvious sign for preeclampsia, but this one, you already have an underlying problem that predisposes you to that. So you can also have chest pain, signs of respiratory infection, signs of heart failure, and pulmonary edema. These are problems you can get. So let's talk about maternal risk factors. I'm just going to mention this. I don't think I'll go into detail with that, especially with the LPNs on here. We have arterial septal defect, which is a maternal risk. So if the mother has this problem, arterial septal defect from childhood, and you are still surviving, your cardiac output was already low, it was a problem. So they have grouped them in rates and mortality rate. The rate at which a fetus can die, the rate at which the fetus or the mother. So these are mortality rate groupings. So we have group 1, group 2, and group 3. So group 1 are those with septal defect, ventricular septal defect, that is uncomplicated, patent ductus arteriosus. We know these are congenital abnormalities in little children. So we have mortality rates number 2, group 2. We have the patients who have mitral stenosis. So babies that are coming with those that have a history of mitral stenosis, or the mother or the baby is being formed and has this problem in the stomach already. It's a problem. Aortic stenosis, coarctation of the aorta. These things are congenital abnormalities in pediatrics. So I know we'll come across them when we get to peds. Then let's talk about group 3. The mortality rate is just 25 to 50%, and that's the greatest percentage. So for mothers with pulmonary hypertension, coarctation of the aorta, endocarditis, Marfan syndrome with aortic involvement, and Isemenga syndrome. So now take notice, this is what I like to tell you, that NCLEX like to mention things like this. So they're going to mention Isemenga syndrome, and you have never heard it. You don't even know what word it is. Then you'll be sitting there and like you're like thinking of guessing. But if you remember ever hearing this in maternity nursing, then you know that you start looking for options that have to do with maternity nursing. Even if you don't remember that it's in the group 3 of mortality rate. Mortality rate is the like the percentage death of a mother who is pregnant, maternal death. If I will just put it in a simple term, mortality rate is maternal death, a woman dying from pregnancy to 6 weeks after delivery. They are all considered mortality in the pregnancy category. So group 3 is 25 to 50% of death for women who have this problem. And group 2, they have 5 to 15%. Group 1 is just 1%. Big. Now let's talk about the interventions you will give for a patient who have cardiac problems. You monitor vital signs, of course, which I know you will do. Now take this as a general management of a patient with every problem. So for every problem that a patient presents to you first as a nurse, your initial step is assessment. And if it's just a verbal walk and the patient comes to tell you, oh, my blood pressure was high yesterday, or my blood pressure is high today. I just checked it in my house. I have it recorded, and this was the number. They show you the figure of the blood pressure. You see it's very high on their phone. They show you the picture. It doesn't mean you just take that for their word, even though you agree with them that the pressure is high, but you also want to confirm. You also want to do your assessment by checking the blood pressure. So if NCLEX tell you the patient said this, don't just go and start giving medication. Don't choose answers that will lead you to starting treatment without tackling your assessment component of the nursing process. So remember the nursing process. You need to gather information first thing before you move. So when you go to sit on the NCLEX, critical thinking is more important, because they are not going to present to you that they want you to follow up with an assessment. They're going to present to you with a client who has a problem and has walked to you, who is pregnant and has a history of, was born with, let me use arterial septal defect. The client was born with a history of arterial septal defect, but the client has been doing well, has no problem, and is now pregnant today and come to the emergency and is ready to start prenatal visit. What advice will you give her, or what will be the first thing to tell the client? Remember your education. Education starts with assessment. So you want to question the client. So how are you feeling today? So you want to follow up to know what concerns the patient has today. So even though they have described a whole long history that the lady is having, but for today, the visit today is just because I am pregnant and I'm coming to start my prenatal visit. They didn't tell you I have headache, I have this, I have that. So you cannot conclude that since the patient had the arterial septal defect as a baby and it survived it, the patient is still having a problem today with the pregnancy. No, until you assess and get information from the patient. So questions you will pick in scenarios like this will be questions that you will ask the patient to further tell you. So besides that past history, do you have any concern? But you are going to take notes of everything. So remember, on the NCLEX, everything you do, it has to be chatted. So another intervention you will do is to limit physical activities and stress, the need for sufficient rest. So this is what you use to educate your patients. So you educate them about rest as well. You monitor for signs of cardiac stress and decompensation, such as cough, fatigue, dyspnea, chest pain, tachycardia. Also monitor for signs of respiratory heart failure and pulmonary edema. So even though the patient is with you right now in the hospital, this is what you do. So if NCLEX tells you the patient have come to you with this, and the patient is being discharged going home, now, instead of intervening, instead of you doing all these things, you are going to educate the patient to monitor for these signs and return back if any of them occur. So it's going to be part of your teaching. This is what you tell the patient. That's why critically, NCLEX will want to know what you will tell the patient. If the patient said, oh, if I have chest pain, I will wait and I will take my aspirin at home and see if it stops before I come in. And you know the patient has a history of coarctation or a heart cardiac disease and is pregnant, you don't have to tell them to wait. That would be a wrong statement. So NCLEX try to look for either wrong statement, correct statement, but it has to depend on you, the teacher. You are the one teaching the patient. So if NCLEX is asking you which of the following statement will be wrong, they assume you should know what to tell the patient with a problem like that. So if you don't know what to tell the patient with a problem like that, how will you even figure out which of this is the wrong statement to make? So that's why interventions are used for teaching staff. What you intervene is what you do for the patient. So teaching is a part of it, and nurses have a major role to do with that. So don't say you're LP and you don't teach, you do a follow-up teaching as well. So you avoid excessive weight gain. Some women, when they are pregnant, oh my goodness, they eat 24/7. So you have to teach them all of this. So avoiding excessive weight gain, you cannot do it. If the patient is with you, maybe you can put the patient on a diet plan, but you cannot force the patient. So you have to teach. You have to instruct. All those things means to teach. During labor intervention, so if a patient has cardiac problems during labor, what do you do for them? You monitor them for vital signs. Of course, everybody, you want to monitor every patient in your care. Place the client on a cardiac monitor and an external fetal monitor, Then you maintain bed rest with the client lying on her side with her head and shoulders elevated. So you elevate the head and the shoulders, and then you make them lie on the side. Don't let them lie flat. Remember, cardiac output, you don't want it to reduce. Then you administer oxygen as prescribed. Yes, of course, a pregnant woman, every small thing that's happened, you want to turn them to the side as the first positioning, and then you want to administer oxygen. So remember your first interventions. I know I will go into detail with that with labor and delivery. Then you want to manage pain in early labor. You want to manage pain early in the labor. So when the woman is dilated, at least above, I think above 4, some people will move it up to 6 centimeters. If the dilation is up to 6 centimeters, you know every 2 fingers is 2. So this is 2 centimeters. If my 1 finger is able to go through the cervix, that's 2 centimeter dilation. 2 fingers, 3 centimeters. 3 fingers, 6 centimeters. So if 3 fingers are able to go, that's 6 centimeters. So if the woman is dilated past that, you don't want to give epidural because it will cause respiratory depression. The last time I checked, it was 4 centimeters. I'm not sure if something has changed. If the woman is dilated up to 4 centimeters, you can give epidural, but above 4 centimeters, some people don't want to give epidural. It can cause fetal respiratory depression. Remember, epidural is a form of anesthesia and it can cause respiratory depression. So let's continue. Cardiology clearance may be required for epidural, spinal, or general anesthetic agents. Cardiologists. You want the cardiac doctor to evaluate the patient heart to see if the patient heart can tolerate it. The patient cardiac system can tolerate the medication before you give. Use controlled pushing effort to decrease cardiac arrest. That's when you are giving the medication. Control system. You just don't go with your hand and then you connect it and then beep, you're pushing it hard on the heart. So excessive weight gain, remember, will put the patient in more stress. Chorioamnionitis. Chorioamnionitis. This is bacterial infection of the amniotic cavity and can result from premature or prolonged rupture of the membranes, vaginitis, amniocentesis, or intrauterine procedures. So these are procedures that can cause this problem. These procedures can cause amnionitis. So if a woman has vaginitis, this is inflammation of the vaginal walls. Amniocentesis, what they do inside, especially those that are above 35, they want to try, mostly they will say 40 and above. They want to do amniocentesis, they want to do intrauterine procedures while the woman is pregnant. Like they open up and then they try to do some procedures during pregnancy. It can cause a bacterial inflammation. Foreign bacteria can be introduced inside the amniotic cavity, and that is a problem. So when you assess, you see that the patient's uterus will be tender and there will be contractions. So uterine tenderness and contractions. There will be elevated temperature. Of course, there will be fever. There will be maternal or fetal tachycardia. So you see either the mother or the baby's heart rate will be so high. And then you have foul odor to amniotic fluid. So if for some reason they are able to get access to the amniotic fluid, it will have a foul odor smell. Then elevated white blood cell, leukocytosis. So take notice of the words and understand them. Then we have interventions. Interventions, what you do for a patient who has amnionitis, chorioamnionitis, or what's the name? Chorioamnionitis. For a patient who have bacterial infection of the amniotic cavity, what will you do for them? You want to monitor their vital signs as well, and the baby's heart rate, monitor for the uterus that is being tender, and you monitor results of blood cultures. Remember, I talked about elevated white blood cells. So if white blood cells are elevated, you of course want to get blood cultures. That's a sign of infection. So if it's an infection of the amniotic cavity, you want to do blood cultures. So before you give any medication, any antibiotic, remember, for anybody you are doing cultures for, the order is for you to be able to draw the blood first, before you start any medication. Then you administer antibiotics as prescribed after cultures are obtained. I just finished that. Administer oxytocin medications as prescribed to increase uterine tone. You administer oxytocin to increase uterine tone. So we know oxytocin causes contractions. So you administer that. Because of this problem, there's inflammation in the amniotic cavity. This probably will lead to the lady having contractions. So you give amniotic oxytocin to help. Then we have you prepare to obtain neonatal cultures after birth. So this scenario is technically describing a lady that is almost due, or a lady that is about to have the baby out. Because with this situation, I'm not sure if it's possible to actually keep the baby in there with that infection going on. The whole cavity is infected with bacteria, and the baby is inside the amniotic fluid and swimming and drinking the same fluid. So the appropriate thing is to prepare for delivery. Let's talk about diabetes. We know diabetes is another thing to talk about as a problem during pregnancy. So pregnancy places demand on carbohydrate. I'm just going to focus on this aspect more than digging into diabetes, because we understand diabetes and we know that it is the inability of the pancreas to secrete insulin. So if the pancreas is not able to do its work. Now, in the case of pregnancy, there's there's a demand in metabolism, in carbohydrate metabolism, and it causes the requirement for insulin to change. It causes an increased demand for insulin requirement. So insulin resistance and hyperinsulinemia may predispose some women. So the need for more insulin will make a woman have diabetes. So in that case, I'm going to jump to gestational diabetes. So before I go to gestational diabetes, I say here that the first trimester, maternal insulin need decreases. So if a lady is pregnant, first 3 months, the need for insulin is decreased. The second trimester, the need for the second and third trimester, the need for insulin actually will increase increase in placental hormones. So because the placental hormones are increasing, the pregnancy level, when they do the beta HCG levels and it's increasing, then the need for insulin is going up higher. So this one will also require the increase in insulin demand. So after placenta delivery, placenta hormone levels abruptly decrease and insulin requirement also decrease. So the moment the placenta is delivered during labor, the moment the placenta comes out of the woman, the demand for insulin also decreases. That's why when a lady has gestational diabetes after delivery, even though they put you on monitoring, but your sugar, if you are not somebody who already have predisposing factors, you are at a greater opportunity to have your gestational diabetes completely cleared off in your body with time. It may not just go down today for you to be normal forever, but with time, it usually go away and you will not need management. Gestational diabetes, this is diabetes during pregnancy. I just finished explaining diabetes here. So the gestational diabetes is usually done, they do screening. They screen every pregnant woman, and the screening period is 24 to 28 weeks of pregnancy, and they do a 1-hour glucose tolerance test. So they have you drink a 50 gram of glucose loaded juice. They put some juice with a lot of glucose in it. It's 50 grams of glucose inside. You drink it and you wait for 1 hour, have your blood drawn, and then they check the glucose level. If your A1C is high. So if you don't, your A1C is too high for that, then they're gonna have you do a 3-hour one. They have the fasting one. So they have you wait, you drink that and you wait for 3 hours. That's a top up after the woman don't qualify for the 1-hour one. So usually this screening is done at 24 to 28 weeks of pregnancy. That's the 1-hour on. And then after this 1-hour on, if the woman don't pass it, if there's a high A1C, then the woman will have to come back for 3 hours on. So you fail the 1 hour, you go higher. Let's talk about risk factors. The risk factors that predispose a woman to gestational diabetes. If a lady is obese, a body mass index of 30 and above, you are at risk for gestational diabetes. We know that the body mass index, they use your height and your weight to calculate BMI. So if you are not a white race, if you are not a white race, you are at risk. So mostly Blacks, I'll tell you African Americans. The last time I was talking about the population stuff, I spoke about African Americans being at risk for diabetes, and I spoke about, I think, the Asians, they are also at risk for diabetes. Hispanics, they are at risk. So the white race do have a lower this thing for that. So if you are in the white race, remember, NCLEX like to also tackle questions that will talk about the race stuff. So previous unexplained prenatal loss, older than 35 years, ovarian cyst syndrome, multiple gestation, first degree elevated relative with, so first degree relative will be like your mother, your father, they're your first degree relative, or your direct sister, the same mother, the same father has it, you are also at risk. So maternal birth weight less than 6 pounds or greater than 9 pounds, they are also at risk. Pregnancy with gestational diabetes, we have glycosuria, you'll be urinating and there's glucose in your urine. Your urine will test positive for glucose. Then essential or pregnancy-related hypertension, the use of steroids. So I want to believe we all understand this because I had a question on the steroid and I think most or everybody got it correct. So we know that any patient that start taking steroid, prednisone, or what's the name? Salomedrol, those are steroids. You are at risk for diabetes. You're at risk for increased blood sugar. Absorption of your sugar is reduced. So you start being at risk. Interventions. I'm not going to talk about all these interventions. I'm going to just talk about a few. So you want to employ diet and medications if diet cannot control blood glucose. So usually, if I am not already a diabetic and I get pregnant and they realize that my glucose is high, they try to put you on dietary management. So dietary management is the #1 management that you educate a patient who has gestational diabetes. So take note that diet is what you will talk about first. So if the patient is taking the diet for a month or a week and is still not working, then you want to put them on medication. That's when they go on medication. So after delivering, the placenta is expected to come down unless you are obviously a diabetic already, then you're going to continue your medication. But if you are not a diabetic, then you want to take, you want to start taking dietary measures serious with a pregnant client. So you want to also encourage moderate physical exercise to burn calories. That will help as well. Then you monitor for signs of infection. You monitor their weight, assess the baby, of course. So if you are the nurse, you want to tell the mother, make sure your baby is kicking. This is a good advice for all situations in a pregnant client. You want to tell them, those above 16 weeks, you want to tell them they make sure they can feel the baby's movement. So you want to schedule a visit. So they are considered a high-risk maternity women or high-risk pregnant women. So they have to be visiting the doctor every 2 weeks until they are 36 weeks. So the normal visiting protocol I had mentioned was 1 in every 4 weeks up to until 28 weeks. From 28 to 36 weeks, they go every 2 weeks. From 36 weeks to 40 weeks or to delivery, they go every week. But for a woman who did not pass the gestational diabetes test, which is usually done between 24 weeks and 28 weeks, from there they start visiting the doctor every 2 weeks until they are 36 weeks. They start every week after 36 weeks and up. Or even if from the beginning you notice that the patient's blood glucose is always high, that's a high risk already. So you let them come to prenatal every 2 weeks. Labor interventions. So if a woman is in labor and has the gestational diabetes, you want to monitor the baby, signs of distress. You want to carefully regulate the insulin and the glucose because the lady is in labor. So you give the glucose so that it doesn't go too high. Postpartum, after delivery, you want to observe the mother closely for hypoglycemic reactions because a precipitous decline in insulin. Remember, I just mentioned that the insulin declines, the woman placenta and all the pregnancy stuff is gone out of the lady. The demand for insulin decreased drastically. So you want to monitor the patient for hypoglycemia right away. So you have to regulate the insulin so that it's not too high, it's not too low. You want to be able to put it under a controlled dose. So you monitor for signs for infection as in postpartum period. Then let's look at the next problem that pregnant women can have. Intravascular coagulation. And this disseminated intravascular coagulation is a maternal problem whereby it's a problem with pregnant women whereby the clotting cascade is activated, resulting in formation of clot in the microcirculation. So we know that there's fetal circulation going on as well, usually immediately after delivery, fetal circulation sets in. So because of the exchange of blood from mommy to baby, exchange of blood from mommy to baby, the clotting cascade, when this is not a normal scenario, it's a maternal risk factor. So disseminated intravascular, there's clotting in the vessels. There's clotting mechanisms that is activated, and it results in clot formation in the circulation between mother and the baby. This is a problem. So the rapid and extensive formation of clot that occur in disseminated intravascular coagulation will cause the platelet and clotting factors to be depleted. It will cause it to be depleted. And the potential vascular occlusion of the organs will be from thromboembolus formation. It can form an embolus. We know about thrombosis. What are the predisposing factors for DIC, disseminated intravascular coagulation? We have placenta abruptio or placenta, yes, that's complete detachment of the placenta. I'm coming there. We have amniotic fluid embolism. We have gestational hypertension. We have I'm going to come to this syndrome later. I'm going to speak about it. Intrauterine fetal death, liver disease, sepsis, and hemorrhage. Let's talk about assessment. So when you assess a patient with intravascular, when you assess a patient for disseminated intravascular coagulation, what do you expect to see? So you see that they have uncontrolled bleeding. They have uncontrolled bleeding. They bleed heavy. They have purpura, they have petachy and ecchymosis. Then they have the presence of blood in urine. The fecal occulta that you will do will be positive. I'm not going to go into detail with that. There will also be signs of shock. Just take notice of that. Let's talk about the interventions. I'm not going to talk about this one. They're not going to drag you that far, especially if you are doing the LPN. Let's talk about ectopic pregnancy. Ectopic pregnancy. This is implantation of a fertilized ovum. I thought I did have a picture of this ectopic pregnancy somewhere. Okay. I did explain this in one of our classes.
Yeah, I remember.
Yeah, so I'm just going to brush through it, but not to focus so much. So when the pregnancy is formed in the fallopian tubes, instead of having it move deep inside the uterus, it gets attached. The baby attaches itself to the wall of the uterus. So when the baby attached to the wall of the fallopian tubes and it start expanding, the moment it ruptures, that's an emergency. You're going to have blood all over the abdominal cavity. Imagine what can happen when you have the intestines and everything in there and the fetus ruptures. It poke everything out. So it's an emergency. That's ruptured ectopic pregnancy. I had the opportunity to do a project and write a full book on a woman that I had taken care of from beginning of admission till the end. She had a ruptured ectopic pregnancy. So I had to start the assessment from the emergency, assess the patient, follow the patient on admission. They go to surgery, they do emergency surgery to close that, and then they stop the bleeding and they close back. Then after that, post-surgery, I had to do care and I had to follow up, do like a home visit to go and check the lady before I completed my book. I wrote a full book on ruptured ectopic pregnancy. And I always remember that experience. It feels so good to have done that. Let's talk about, so with the patients who have the ectopic pregnancy, you also want to administer antibiotic because it's a risk for infection as well. They are at risk for getting infection. You want to give them Rogam if it is prescribed for an Rh negative. So just take notes, Rogam for Rh negative. The patient asks you, why am I getting Rogam? You walk in and then they throw you a question. So you have a woman that is 27 weeks pregnant, and then the doctor comes to tell you, or the woman has threatened abortion and is bleeding, and the woman tells you, oh, the doctor just said I need some injection. I need some injection to be able to sustain the pregnancy, but I don't know why I should get injection. This is my second pregnancy. The first one, I didn't have to take any injection, but my baby is doing any fine. I don't know why they're giving me that injection. You should be, your mind, critical thinking tells you that, okay, so for 27 weeks, the woman has bleeding and is going to get her medication, or the woman says she had no problem with the first baby. Remember, first babies with Rh negative don't have a problem. It's the second baby who have a problem. It's not Rh positive. The normal you want is Rh positive mother, Rh positive baby, and you are good. But if the mother is Rh negative or mother is Rh positive, that is good. But baby comes out as Rh negative, or the father is Rh negative, they can start having a problem from 28 weeks. So you want to give Rogam. So that's where you give it. So this lady asking you that question, you want to tell the lady that the medication they are going to order is because there's incompatibility between you and the baby. And that incompatibility, your body did not sense it in the first pregnancy. It doesn't happen in the first pregnancy because your body, you have never been pregnant. But if you ever had a miscarriage, that is considered pregnancy. The second one you get pregnant, your body will sense it. So just take note. First time pregnancy, you may not have any problem. Second time pregnancy, or third, fourth, five, your body starts sensing it. That's why you see some people get married and then they have a baby for the first time. And after that, every time she get pregnant, she get miscarriage. Every time pregnant, she's miscarried. I know my people like to say spiritual. Let me leave it there. Okay, let's talk about fetal death in utero. Fetal death in the uterus. What causes it? So fetal death in the uterus refers to death of the fetus after 20th week. So remember, before 20 week, I told you that one was abortion. It was abortion before 20 weeks. So from 0 to 20 weeks, you are good to take out the baby if you choose. But, or if for some reasons spontaneously nothing caused it and the baby come out, that's miscarriage and abortion. But where the baby is 21 weeks, 22, 23, up to 40 weeks, and the baby dies in your stomach, or you decided that you want to abort it, you didn't go for medical advice, and then you drink something and kill the baby. That's fetal death intro or in utero, fetal death in the uterus from 21. Consider that. The client can develop disseminated intravascular coagulation if the dead fetus is retained in the uterus for 3 to 4 weeks or longer. Some women don't even know that the baby is dead. So it can cause clotting. It can activate the clotting factors in your body. Remember, when the exchange of fluid from the mother to the baby through the placenta is not working well, all the blood in there start clotting. So when you assess such a woman, you will find that there is no fetal movement. The fetal movement will be absent, the heart tone, maternal weight loss. The woman start losing weight. You see the stomach start reducing in size. There is no evidence of fetal cardiac activity. Well, that is when you go to the extent of checking the fetal heart rate and all those things. But you see that physically the mother will be losing weight. You see the fundal height reducing. You really cannot feel the movement of the baby. What will you do? What are your interventions as the nurse? You have to prepare for birth of the fetus. So the baby is dead. If the baby is 30 weeks and the baby is not moving and all those things, when you check and the baby is dead, you have to prepare to take that baby out. So you prepare the woman pre-operatively for surgery. So you support the client decision about labor, birth, and postpartum. So you support their decision. So the client say, this is how I want to do it. I want to have a C-section to take that baby out. You support them. But sometimes you have to coach the client to take the right decision. You have to explain all the options for them. You have to provide support, of course. You have to be supportive. Don't tell them, oh, I have too many babies, it's enough. Don't worry about it. That's wrong. So therapeutic communication comes everywhere. So all the responses you are going to pick on the NCLEX, make sure you look for responses that are more healing, that are more heart comforting. That's why sometimes you try to motivate the client by saying, good job, you did well for trying to do this yourself. So you have to be supportive. You accept behaviors such as sadness, anger, hostility from the parent. Don't tell them, don't cry here. Please, you are crying too loud and you are disturbing. Find them a room, let them grieve. It's part of the grieving and the loss process. They are losing a baby and they have carried this pregnancy for weeks and it's sad. So leave them, give them an opportunity, assist them, be supportive. Let your responses be therapeutic. So we have cultural, spiritual, and religious practices and beliefs that are important to consider when you are caring for a parent of a fetus who has died. So when you have a parent that a fetus have died, you want to be culturally aware. Don't behave like this is the hospital and their culture and spiritual beliefs doesn't function here. So the mother say, I need my pastor to come in and then pray with me. Give them that opportunity. You can look for the chaplain for them. It is okay. And then you ensure that you respect what their belief is. I had a patient that I was taking care of who had a 4-year-old, brought a 4-year-old, the 4-year-old died in the hospital. The woman was standing with the baby. So when I'm doing rounds and I got to the baby and I'm assessing, I did the vital signs, I realized that the baby was kind of gasping for air. So I did the vital signs and everything. I realized that it wasn't working. So I started CPR on that little baby. And the moment we started the CPR, the mother was standing there watching. The moment she saw the foam, she saw foam coming out of the baby's mouth. That was it. She just said she's going to the bathroom. She was already crying throughout the process of the CPR. She said she's going to the bathroom. And I didn't know culturally from that particular culture, when their relative die, they don't want to be in the same location with the dead body. So the woman walked to the bathroom and never came back. That was it. She ran away. We had to look, come and carry the baby. That's culturally. So when they had the family to talk to them, they told us that their culture, because she's a woman, she's not supposed to be there. And she realized the baby was dying. She's home right now crying. She's feeling the loss, but she cannot be with the baby. Culturally, she ran away and left us with a dead body. That was that. She was the only one that came with the baby as well. So we didn't know what to do in the first place. And she was new to the community. She was brand new. So it was very hard. I always remember that experience. So culturally, respect what they believe in. So they want to mourn, let them mourn. That's a loss. Don't say it's a baby you have never seen, there's no problem. Some nurses, you see them on the floor and they are different. They are like people who are here to talk shit to you. Hepatitis. Hepatitis is part of GI system I had discussed. I'm not digging too much into it, but we have some women that have hepatitis. I'm just going to explain that shallow and we move on. So if a mother is hepatitis positive and the mother has given birth, the baby gets the hepatitis vaccine. That is the hepatitis B immune globulin. The baby get the vaccine soon after birth, usually the first 24 hours. So if I am hepatitis B positive and I get pregnant and I give birth, they're going to monitor me all right. But during the delivery process, they are going to be very careful. You treat it like the HIV because it's also bloodborne. So bloodborne and secretion. So after delivery, first 24 hours, I don't breastfeed the baby. They give the baby the hepatitis B vaccine. Is the regular vaccine the baby will get in the subsequent immunization times, but you give the baby immediately after birth, and then you let the mother can breastfeed after the baby have gotten the vaccine. So hepatitis B mothers who are positive, they can still breastfeed. Please take notice. Hepatitis B mother who tells you I am hepatitis B, I'm scared to breastfeed, You have to explain to them the moment the baby get the vaccine, the first 24 hours after delivery, the mother can breastfeed the baby after the baby got a vaccine. So if the baby got a vaccine 20 minutes or 1 hour after delivery, it's okay 2 hours later to start breastfeeding your baby. The baby got the vaccine. But if the baby don't get the vaccine, you want to advise the mother not to breastfeed, to hold her. So you inform the mother that the hepatitis B vaccine will be administered to the neonate and that a second dose should be administered at 1 month after birth and a third dose at 6 months after birth. You know that hepatitis have 3 vaccines, so 3 vaccines. So since it's 3 vaccines, first dose is administered at birth, second dose is 1 month time, you bring the baby back, and the third dose is when the baby is 6 months. So that's the protocol for administering hepatitis B, but you want to support breastfeeding after neonate treatment for hepatitis B is not contraindicated if the neonate has been vaccinated. So I just mentioned that. Let's look at hematoma. Hematoma occurs following the escape of blood into the maternal tissue after birth. So I'm not going to dig too much. When you assess a woman who has hematoma, there will be abnormal severe abdominal pain or abnormal severe pain in the abdomen, pressure in the perineal area. Client says that she feels like she has to move bowel or she has to go to the bathroom. Palpable sensitive swelling in the peripheral area with discolored skin. There will be inability to void. So even though the client will have the sense of voiding, they still cannot void. There will be signs of shock. They will be pale, tachycardia. And now interventions is, of course, your vitals. You monitor the client for the pain, and then you prepare for forceps delivery should be performed for a client who has hematoma. Then you want to apply ice to the hematoma site, and you want to administer blood replacement as per count, so as prescribed. So if the client if the client lost blood, you want to give blood transfusion as prescribed. I see a question in the chat room. It says, what if the mother has other types hepatitis? Would she be able to breastfeed after the baby is vaccinated? Yes. So remember, hepatitis, their management are different. Some of them, they are not body fluid transmitted. They are not blood-borne and all that. So if it's hepatitis C, there is no problem breastfeeding. Other hepatitis, one, I think hepatitis A is fecal oral. That is no problem. Hepatitis C is a question because that one is also blood-borne. It's more like transmitted similar to that of the B. So hepatitis A, that is fecal oral, you are not worried about that. So it depends on the kind of hepatitis. Usually they are concerned about hepatitis B because that one to remember, after the baby get the thing and start breastfeeding, the mother can go on treatment after delivery. You don't give hepatitis B mother any of the hepatitis medications. They will have the baby before they start the treatment. So that's why the baby will take the vaccine first and then start eating from the mother. So other hepatitis is not actually a big deal with breastfeeding. You can breastfeed with the other hepatitis, but the B is to be vaccinated before. And I don't remember hearing about hepatitis C vaccine actually. I don't remember hearing about it having a vaccine because usually they always say that one doesn't have treatment and it clears away from the liver. So those ones, I am not like, you don't need to stop breastfeeding for that. It's hepatitis B that is the question, because the moment the baby starts breastfeeding, his body fluid getting in contact, the baby can get it. So take note of that. I hope I answered the question. Does anyone else have a question before I continue? I'm going to move straight to HIV/AIDS. Does anyone have a question or you want to take a break? Let me know. Which one? Anybody has a question?
No,
Any question?
I don't have any questions.
Okay. So let's see. Yeah. Can we take a break?
Okay.
We can take a break, right? So we are going to come back at 45, right? Yeah.
Okay.
We'll come back 7:45.
All right.
Okay.
All right. Thank you.
Thank you so much. So I'm going to pause the video so that we take a break. And if you have any question, please don't hesitate to let me know.
Okay.
Okay.
All right.
See you. So let's talk about HIV/AIDS. HIV/AIDS. So we know HIV is the causative organism for or agent for AIDS, acquired immunodeficiency syndrome is the disease itself, but the causative organism is HIV, human immunodeficiency virus, human immunodeficiency virus. It affects the human immunity. It's a virus that affects the immunity of a human being. And if you get it, you are at risk for acquired immunodeficiency syndrome. So the syndrome is the one that we call AIDS. But HIV is a human immunodeficiency syndrome, virus that will affect your immunity. So take note, don't confuse it at all times. They say the patient has HIV, don't go and start managing the patient for AIDS, because there can be other acquired immunodeficiency viruses that will be around. So take notice of your management. So women affected, I'm talking about maternity nursing. Remember, we are on maternity nursing. So we are talking about mothers with HIV/AIDS. HIV/AIDS. So mothers with HIV/AIDS. Before that, I want to make sure that we all understand the infection control practices with HIV/AIDS. But also under that, I want to let you know that on the NCLEX, you treat all patients as though they are all infected. So treat all patients as though they are all infected. You use standard precaution to care for all patients. But the patient is HIV/AIDS or hepatitis B, they're all blood-borne and body fluids. When it penetrates through any cut, any opening on the skin, you can get it. So women with HIV/AIDS, they may first show signs and symptoms at the time of pregnancy or possibly develop life-threatening infection because normal pregnancy involves some suppressions of the maternal immune system. So pregnancy itself suppresses the maternal immune system. So a pregnant woman who has been HIV positive may not be aware that they are positive, but when you get pregnant, it now makes you sick and it suppresses your immunity furthermore. Then that's why they do the HIV screening as part of the maternity screening that they do. We spoke about it in the last video, the tests that are done during pregnancy. So there's repeated exposure to the virus during pregnancy through unsafe sex. So let's say your partner is positive, is HIV/AIDS positive, and there's repeated exposure, and you are still pregnant, or you do like IV drugs. Those are the major causes, blood-borne and IV drugs. That's sexually transmitted and IV drugs users. They are at higher risk. So it can increase the risk for transmission to the fetus. So if you are positive and you stay away from risky behaviors like that, the risk for your baby might be less. But if you constantly pre-expose yourself to things that will have more of the virus in you, you are at risk for having the baby infected in your stomach. Now, 3 drug combination, highly activated antiretroviral therapy. Highly activated antiretroviral therapy. I remember I came across that word somewhere, and I decided to move on. But this is the management for patients that are HIV positive. So highly activated antiretroviral therapy treatment, which is monitored by an infectious disease specialist, is recommended to reduce mother-to-child transmission. So for women who have the HIV plus, they want to try to reduce the infection to the baby. So we have zidovudine, which is recommended for the prevention of maternal to child transmission, and is administered based on the following recommendations. Antepartum. Did I talk about this, or I just hit on it and I left? Antepartum, so before pregnancy, orally beginning after 12 weeks of gestation. So when you get pregnant, from the time you are pregnant, they start giving it to you by mouth until 12 weeks. So maternal highly activated antiretroviral medication is given to reduce the viral load to undetectable. So they want to reduce the viral load so that it will be undetectable. Remember, the first 12 weeks is the fetal formation stage. The first 12 weeks is when the baby forms. So they give that medication, they give zidovudine as one of the medications that are to help prevent maternal to child transmission for the first 12 weeks. Then intrapartum, within the pregnancy. So during the pregnancy, we have intravenously. So they give it to you through an IV when you are in labor. Zidovudine is given 1 hour before a vaginal birth and 3 hours before a C-section. 3 hours before C-section. So take notice of that. Zidovudine, you give it 1 hour before a patient has vaginal birth. And if the patient is going to have a C-section, you give it 3 hours ahead of time. Postpartum in the form of syrup to the newborn, 2 hours after birth. So they give the newborn to zidovudine, but that one is a syrup one. So they give it to the newborn the first 2 hours after delivery, and every 12 hours for 6 weeks. Every 12 hours, once a day. Or once in 24 hours, twice in 24 hours. So one a day for 12 hours. They give that for up to 6 weeks. So the first 2 hours of life, the baby is supposed to get zidovudine, and then continue after the 2 hours. The next day, the child starts taking it every 12 hours for 6 weeks of their life. Then you want to keep the baby in the NICU. At the beginning of the therapy, you want to monitor how the baby reacts. Imagine a newly born baby start taking HIV medication. So for mothers who are HIV positive and they have babies, this is what they do for them. So let's look at the transmission. We know it's sexual intercourse, and we know it's through IV drug users. They are at highest risk for getting this infection. So risk to the mother, a baby with HIV is managed as a high risk because she's vulnerable to infection. So the mother and the baby, they manage them as one of the high risk stuff because the baby too is at risk for infection, and the aim is to have the baby not get it. So let's talk about the diagnosis. I spoke about the ELISA test. I'm not going to repeat that. They do the ELISA test and the immunoassay test. So we do the Western blot test is a confirmatory test. Let me go over this. So the test used to determine the presence of the antibody HIV enzyme linked immunoassay, that's the ELISA test, is used to detect the HIV enzyme. And then they do the Western blot and immunoassay test, IFA. So single reactive ELISA test by itself cannot be used to diagnose HIV test. And the test should be repeated with the same blood sample if the result is again reactive. Then follow-up test using the Western blot. So take note, ELISA test is the initial test they are going to do, but the Western blot is the confirmatory test. After they repeat the ELISA test and it come back positive the second time, then you go for a third one, and the third one is the confirmatory test. So remember, Western blot is confirmatory test. ELISA test is good, it can come back positive. But what the Western blot will say is what will actually make it standing as HIV/AIDS positive. Sorry. So a positive ELISA that fails to be confirmed by the Western blot or the immunofluorescent assay should not be considered negative, and repeated testing should be done. So in case the ELISA test fail, it should be confirmed by this, by the Western blot or the IFA in 3 to 6 months. So don't just leave it. I think I said that before. Now, the prenatal period, you want to institute measures to prevent opportunistic infections. You know, when a patient has HIV, it attacks the immunity. So we have opportunistic infections like diarrhea that sets in. We have rashes. You see them with so many complaints. Then we have the intrapartum within labor, within the pregnancy during labor. If the fetus has not been exposed to HIV in the uterus, the highest risk exists during delivery through the birth canal. So if the baby is in the stomach and has not gotten HIV, the highest risk is through delivery. So the people will do the delivery with a special treatment to try not to have the baby get exposed to it. Let's talk about the postpartum period. You want to monitor for signs of infection. I spoke about it already, getting the baby into the NICU and giving the baby the vaccine. Breastfeeding is likely to be restricted. Follow healthcare provider recommendations regarding breastfeeding. So with HIV, one thing I know is that mostly the baby will not breastfeed. We recommend bottle feeding for that baby. They don't recommend the mother to breastfeed. Remember hepatitis B, the baby get a vaccine and it's okay. But HIV, remember the baby have to take the zidovudine for the syrup for 6 months, 3 to 6 months after delivery. So the HIV/AIDS, the hepatitis B, the moment the baby get the vaccine, the first 24 hours, they are good to breastfeed. But with HIV/AIDS, they are not okay. So you want to follow, you advise the mother to follow healthcare recommendations, but usually breastfeeding is not advised. We have hereditary mole. Hereditary mole is a form of gestational trophoblastic disease that occurs when a trophoblast, which are the peripheral cells that attach the fertilized ovum to the uterine wall, develop abnormally. So we have trophoblasts. These are cells that will help the placenta or the fetus that is being forming when there is replication attach itself to the uterine wall. So when those ones are diseased, it prevents them, it develop abnormally. So if it's abnormally and the ovum has to use that to attach to the uterine wall, you can see there's a problem. So the mole is like a mole that is formed. If you know how mole grows, you will see that it's a mole that forms. So instead of having the uterus or the baby come to attach itself to the uterus, the ovum that is being formed into a baby attached to the uterine wall, there's this mole on the uterine lining that is preventing it. So it's an abnormality as well. So in this case, when you have a lady that has that problem, you'll see that the mole will manifest as an edematous or grape-like cluster. Grape-like clusters that may be non-malignant or may develop in the choriocarcinoma. It can develop into a cancer in the uterus. So this will be detected through an ultrasound. Assessment, the fetal heart rate will not be detected. Imagine, so the baby is not able to attach itself. How will growth be evident? There'll be vaginal bleeding, and which may occur by the 4th week or not until the 2nd trimester. So 2nd trimester, you start bleeding. Signs of preeclampsia, there will be progressive blood pressure elevation before the 20th week of gestation. So note that preeclampsia usually occurs after 20 weeks of pregnancy. typically in the 3rd trimester. So usually preeclampsia, from 20 weeks, you start monitoring a woman. So if you are educating a gestational a pregnant woman, you tell them after 20 weeks, start checking. Let us know when you have edema of your feet. Start checking when you have a headache. And then when you feel unusual, when you feel funny, feel your blood pressure is not right, you get dizzy, come around, let's check you up. So it's part of the advice you give to a lady when they are up to 20 weeks pregnant. So those are the possible interventions you want to give them. Let's talk about hyperemesis gravidarum. It's a problem in pregnancy. We are talking about risk conditions in pregnancies. So the problem with hyperemesis is fluid and electrolyte imbalances. Fluid and electrolyte imbalances, usually in the 1st trimester, you have the patient vomit nonstop. So fluid and electrolyte imbalances. So when you have a patient, your nursing diagnosis or your priority concern is loss of nutrient or electrolyte in the body, dehydration, number 1. So when you assess, there will be like non-stop vomiting, persistent vomiting, weight loss, dehydration, and electrolyte imbalances. We have interventions. You want to initiate measures that will alleviate this by giving them medication. If that one is not successful and weight loss and fluid and electrolyte imbalance occur, intravenously administer fluid and electrolyte replacement or parenteral nutrition may be necessary. So parenteral nutrition may be necessary because you don't want electrolyte imbalances to occur. So vital signs, weight, calorie count makes sense for this situation because they keep vomiting. Monitor the laboratory result for electrolyte imbalances like the hemoglobin. You want to monitor sodium, potassium, all those vitamins. You want to monitor them. Then we have monitor urine for ketones. Ketones, when there's present, it shows in dehydration. Presence of ketones in your urine will mean you are dehydrated. Let's talk about the fetal heart rate and activities and growth. You want to monitor that one too. How is the baby growing? If mommy is not able to eat well, how will the baby grow well? Then you want to encourage small portion, intake of small portion, low fat, easily digestible carbohydrates such as cereal, rice, and pasta. You want to encourage these ones. You want to also encourage them to take fluid and liquid in between meals to avoid vomiting in between meals. That's the teaching. And then you teach them to sit upright after they eat. You're teaching them to prevent hyperemesis gravidarum. Let's talk about hypertensive disorders. Hypertensive disorders. In fact, if you have had hyperemesis gravidarum, you understand what it is. I am an example of that. It's so bad. Then let's talk about hypertensive disorders. 4 major categories of hypertensive disorders will include preeclampsia, chronic or pre-existing hypertension, chronic hypertension, and superimposed preeclampsia, gestational hypertension. So it's all talking about preeclampsia inducing hypertension. We know that preeclampsia comes with a sign of high blood pressure, and people that get hypertensive because they are pregnant. Then we have the blood pressure will be elevated and can lead to preeclampsia and then eclampsia. Eclampsia is a complication of preeclampsia, and that comes with seizure. When there is a seizure activities, that's preeclampsia now. So you want to also monitor that. I'm going to leave it there like that. You want to assess the patient for protein in urine. I'm talking about eclampsia now, preeclampsia. Monitor them for protein in urine. And protein is not a reliable indicator of preeclampsia, but you want to also monitor if there is protein in the urine, but it's not a reliable indicator that will tell you that the patient is preeclamptic. Evidence demonstrates that kidney or liver function can occur without signs of protein, and that the amount of protein in the urine does not predict how severe the disease will progress. So the amount of protein in your urine does not predict how severe you get the preeclampsia for. So we have persistent hypertension. These are the signs that will suggest eclampsia, preeclampsia. Persistent hypertension, swelling of the face or hands, headache, changes in body eyesight, that's blurry vision, pain in the upper abdomen or shoulders, nausea, vomiting in the second half of pregnancy, sudden weight gain, difficulty breathing. So usually if a woman is in their last stage of pregnancies and they get eclampsia that is getting complicated, non-stop high blood pressure, they end up doing a C-section. You want to recommend a C-section in the end. Risk factors. So the risk factors will be previous pre-eclampsia or previous gestational hypertension. So if I was pregnant before and I got hypertension, I'm at risk. If I am a first-time mother, I don't even know how my pregnancy is going to go, so I am at risk. Family history, women who are 40 plus, African Americans. Remember, when it comes to hypertension, you want to think African Americans first, or cardiac diseases because of hypertension. So people with chronic diseases such as high blood pressure, kidney problems, they're at risk. Body mass, that's obese patient. Body mass that is greater than 26, metabolic disorders or metabolic syndrome. Multifetal, those that have multiple babies, like twins, quadruplets, and all those things. So you also want mothers with hereditary mole, all those complications count. Then we have complications of hypertension and gestational hypertension disorders. It can cause a placenta abruptio when the placenta detached. We talked about disseminated intravascular coagulation, fetal growth restriction. The baby will not be growing well. The placenta will not get enough blood supply. What will you do for this patient? What will you do for this patient? You want to closely monitor their blood pressure and their weight. This is management of a patient with preeclampsia. They can put these steps, they can pick 4 of these steps and want you to do a drag and drop. What do you know about caring for a patient with preeclampsia? You want to closely monitor their weight and blood pressure throughout the pregnancy. The client may need to be taught how to take her blood pressure at home, weekly or twice weekly healthcare visit. They are high risk. So the moment a patient from 20 weeks start developing swelling of the ankles and all those things, then you want to, or swelling feet, high blood pressure, then they are now considered high risk. They were normal from beginning till now, but they are now high risk. So you want to encourage them to come for visit twice, to visit the doctor either every week or twice a week, depending on the severity. And then delivery may be recommended at 37 weeks of gestation. The moment you wait for that baby to be good, at 37 weeks, delivery is recommended. Usually, they will have to do C-section or they can induce the labor at that point. So take notice of preeclampsia and hypertension management. When it's not controlled well, the baby will have to be delivered. They call for emergency C-section and they take that baby out. Then you want to monitor for the baby's activity in the stomach, fetal count. You're counting how much they are kicking. So you monitor their intake, the intake and the output for the mother. 30 ml of urine indicates inadequate renal perfusion. This is a complication. You want to make sure the kidneys are working. So you encourage frequent rest. You tell the client to lie in the lateral position. You know, the lateral position for preeclampsia with severe features. The client will also need to be hospitalized for those who have highly elevated BPs. Then you give medication as prescribed to reduce the blood pressure. Then some women will have to be home, but they put them on medications and they teach them how to monitor the blood pressure. If it's not working, they come back. So you also tell them to monitor deep tendon reflexes. You know, when the patient has the eclampsia going into the preeclampsia going into the eclamptic state, the reflexes are impacted. Reflexes are because they tend to have a seizure. So you want to also caution them, you want to advise them, you want to teach them about that, the complication of preeclampsia, and tell them to report as soon as possible. I'm not going to talk about this assessment of the reflexes. But note that this is usually when eclampsia sets in and there's a seizure. So we have the reflexes, we have the biceps, we have the normal response of it. I'm not going to talk about those ones because most people on this are now LPNs, and we don't need to go in further. For those who are RNs, you can just go and read this and you get the information. Grading response. So you grade all these reflexes. Let's talk about eclampsia. Eclampsia. So these ones are when preeclampsia is getting complicated. And with this, we really need to keep the patient. Eclampsia is seizure. So the patient was having preeclampsia. Now the patient has a seizure. That's what you will see. Priority intervention. I decided to go straight from the assessment. This is what you will see. You will see that the patient is seizing, pregnant, and is having a seizure. Because the blood pressure is being high and not stopping, the patient goes into a seizure. So the priority nursing action that you will take when there's a seizure or when there's eclampsia, you want to remain with the client and call for help. Please remember seizure management. You never walk away with the patient from the patient. You try to maintain oxygen. You try to maintain their airway, keep their airway patent. So you ensure an open airway. You turn the client on her side and administer oxygen by face mask at 8 to 10 liters per minute. So you don't want to walk away and leave this patient. You want to turn them on their left side. Most times, most pregnant women, when they're having difficulty with breathing problems, you want to turn them on the side and administer oxygen. That's what you want to do. So you monitor the fetal heart rate patterns. So you have a fetal monitor as well. You're checking the baby. After the seizure has ended, you insert an oral airway and suction the client's mouth as needed. So you want to help the client to maintain the airway pattern to be able to exchange gases. Then you prepare for delivery of the fetus after stabilizing the client if warranted. So if the doctor say we are going to have an emergency C-section, that baby needs to come out, then you have to prepare. That's the pre-operative preparation for C-section. So prepare for delivery. You document everything that has happened with the seizure and the occurrences and the interventions that were done to help alleviate it. So typically it begins with twitching around the mouth. The body then becomes rigid in a state of tonic muscular contractions. That is 15 to 20 seconds. So it's like a quick seizure. It doesn't take you all day seizing, no. So we have the incompetent cervix. What is incompetent cervix? So this is the dilation of the cervix, most often in the 4th or 5th month of pregnancy. Most often in the 4th or the 5th month of pregnancy, incompetent cervix. When the cervix starts dilating, start opening up, it can no longer hold the pressure of the growing fetus. So surgical procedure is to place a cervical cerclage. So they will do a clip, they will do a surgical procedure and they clip the uterus, the cervix. They clip it or they try to pull it together and then they close it. They manually will do a surgery for that. So when you assess a patient with that, you see bleeding. The fetal membranes will be visible through the cervix. You can see the baby. Remember, the cervix is supposed to start opening up when the woman is in labor, and it's a natural process. But here is the case, there's an abnormality. It start opening on its own and the baby is about to pop out. This have caused miscarriages as well. Remember, I spoke about incompetent cervix. So they clip it. The cervical cartilage is removed at 37 weeks of gestation or left in place, and a C-section is performed. So they can either remove it or they can take it out when the baby is due. 37 weeks is a full-term baby, so they can decide to take it out. Now let's talk about infections in pregnancy. Infections in pregnancy. In fact, I'm going to talk about the toxoplasmosis. Usually they use the acronym TOUCH. They use this acronym TOUCH. If you haven't seen it before, they use the acronym TOUCH. And TOUCH starts with T, which is the toxoplasmosis. And this one is caused by infection with the intracellular protozoan parasite. It produces a rash and symptoms of acute flu-like symptoms in the mother. the mother will have like flu-like symptoms. So the organism is transmitted to the fetus across placenta. So if the mother has toxoplasmosis, the baby can get it. So you educate the client regarding infection, which is critical. I always hear people say this is always when you get exposed to, is it cat dander or I think some mouse dander, but toxoplasmosis is not a good thing. So it is transmitted to the mother through ingestion of raw meat, or handling of cat litter of infected cats. So if the cat has it, the cat is in your house and they have toxoplasmosis, you can get it. So this is not, COVID is not the only first thing we are going to hear that is coming from an animal like bats, that they eat it. Cats that we live with in the house, if they have toxoplasmosis and you keep handling it and you get pregnant, you can get it and you can transfer it to the baby through the placenta. So you educate them. The O is other, and the other has to cover HIV, syphilis, and all STDs. I'm not going to talk about it because I spoke about it in the first video. I spoke about STDs, syphilis, HIV, chlamydia, and all that. I didn't talk about, I spoke about German measles, but this is just an organism. It will transmit through the placenta, the German measles. So if you have it, it can go to the baby through the placenta. So it causes congenital defects of the eyes. So usually you see that the baby is born with eye problem, German measles. So they have to do blood titers. And postpartum period, the client has to wait for 1 to 3 months as specified the provider before becoming pregnant. So if you, the mother, your titers are low, if you have never been vaccinated with the MMR, the measles, mumps, rubella, and they check and your titers are low, so they make sure when they check and your titers are low, they can give you an injection. They can give you an injection, but before they give you that injection, they want to make sure that you are not pregnant. So they will do a pregnancy test first, and then they tell you to wait for at least 1 to 3 months before you get pregnant. Because you don't want the infection transmitted to your baby. So the other problem I have is cytomegalovirus, which is C. So the C here, did I jump the R? The R is the German measles. Now the C is cytomegalovirus. This is organism transmitted through close personal contact. It is transmitted across the placenta to the fetus. So you see most of these touch acronym disease problems, they go to the baby through the placenta. And the cytomegalovirus, it can cause enlarged liver. It can cause symptoms like jaundice, enlarged spleen, hearing loss, and seizures. So you think the baby has jaundice. You think the baby has jaundice. The baby will be born with a yellow skin. That's cytomegalovirus. It affects the liver. Herpes simplex virus. Herpes simplex virus affects the external genitalia, vagina, cervix, and cause draining, painful vesicles. So that's what the H in the acronym TOUCH stands for, herpes simplex virus. So this is simplex virus. It affects the external genitalia, vagina, cervix, and draining. So this one, acyclovir, is a medication. It's an antiviral medication. It's an antiretroviral medication, acyclovir, and it may be prescribed to treat recurrent outbreaks during pregnancy. So that means it is safe to give in pregnancy or use as suppressive therapy late in pregnancy to prevent an outbreak during labor and birth. Now, these are the other staph and the staphylococcus group B. Group B staphylococcus, it also may be included in the acronym, which is on the other ones. The other, as had mentioned, that is the STDs I spoke about. So we have streptococcal group B. Group B streptococcus, it is a leading cause of life-threatening prenatal infections. So it is colonized in the vagina, the rectum, the cervix, the urethra of a pregnant woman. So you will get it. Multiple gestations. Multiple gestations is also another risk we want to quickly run over. So I'm not going to talk into that. We know multiple gestation is where you have had multiple children, or you are having twins. You're having so many twins. So it's because of the twins. Most often they will have a preterm delivery. And when the children are born, they will have low birth weight. So take a pregnant woman, for instance, most often from 34 weeks, they try to take the babies out from them because the stomach gets bigger. And then those who have like 3, 4 children, they put you on bed rest, and then they do a lot of monitoring. So it's also a risk in pregnancy. Placenta abnormalities. I don't want to miss this part. I want to make sure I get here before I stop the class for today. Placenta abnormalities. Let's talk about placenta accreta. This is an abnormally adherent placenta, and it occurs when the placenta penetrates the uterine muscle itself. Placenta accreta occurs when the placenta goes all the way through the uterus. It goes through all the way through the uterus. Instead of just attaching itself on the wall of the uterus, it digs deeper inside the uterus. So there can be bleeding, and immediately after birth, because the placenta does not separate easily. So if the placenta is all stuck inside the uterus, then it is not ready to come out. It is not ready to come out. So there can be bleeding and difficult to have it come out after the baby is born. Then interventions is monitor for bleeding and shock after delivery. You prepare client for hysterectomy. It is advisable to have the womb come out because trying to bring out only the placenta sometimes is hard. It's going to cause more bleeding. Remember, the uterus is one of the muscle in the body that causes a lot of bleeding. And when a lady is pregnant, because of the increased blood volume and the hormonal changes that pull a lot of blood to the uterus, bleeding from the uterus can kill right away. Or within some few minutes. So let's look at placenta previa. Placenta previa. This is an improperly implanted placenta in the uterine wall. Remember, I told you when there's gestation, it moves straight from the fallopian tubes after the ovum is fertilized by the ovaries. It moves straight through the fallopian tubes and it attaches to the womb. So we have 3 types of it. Are we seeing the screen? What is it? We have placenta, we have the partial, complete, and marginal. So this one is the partial attachment. Partially, it has not attached well. It did not attach well. Oh, am I talking of attachment? Yes, it's not well implanted. It is not well implanted. We have this one that is partially implanted. You see part of it covering the cervix. Part of it, this is the cervix. The hole down here is the cervix. And part of the placenta is covering that. So instead of having it well implanted, it has partially, does not attach well. And this one is the complete one. So the internal os is covered entirely by the placenta when the cervix is dilated fully. So even though the cervix is dilated, but the placenta has come to attach itself on the cervix. So we have partial, complete, and marginal. Marginal is a little, it gives the cervix a little space, but remember it should not attach this way. So these are the abnormalities: placenta previa, abnormal implantation of the placenta. It does not plant itself well. So when you assess, there will be sudden onset of painless. Now take notice of this description here because you're going to have placenta previa. Placenta abruptio show you another type of bleeding. So you're going to have bright red blood in placenta previa. So placenta previa, there's bright red blood or bright red vaginal bleeding. And this one occurs in the last half of pregnancy. So the problem starts manifesting itself in the last half of pregnancy. It's not seen. It is seen on ultrasound and all scans that will be done. But in the last half of the pregnancy, that's the 3rd trimester, the bleeding starts. So the uterus is soft, it relaxes and non-tender. The uterus is not supposed to relax. It's supposed to be able to hold the uterus. So where it relaxes, it's just all about bleeding. So when you see the uterus relax, it's going to be too soft. There's no contractions, so it's not going to stop. It's going to start oozing out blood. Fundal height may be more than expected if for gestational age. So the height of the baby or the fundus will be higher on fundal examination as expected. Then we have the interventions. You want to monitor the vital signs and fetal heart rate, prepare for ultrasound to confirm the diagnosis. You want to do vaginal exam or any other. You don't do vaginal exam with this problem because it will stimulate the uterus. When you put your hand in there, usually if a lady is of age, if a lady is up to, let's say, 37 weeks, or the hormonal imbalance and the hormonal changes goes with pregnancy. When you do vaginal test, vaginal exam, or when you try to touch the pregnancy membranes, you can cause contractions. So usually another way to induce labor is to just put the hand there and burst out the fluid. When they try to stimulate that area, when they try to stimulate the cervix, it can cause a whole lot of contractions and delivery. So vaginal examination is contraindicated in patients who are having this. That's why you do ultrasound to be able to detect that. So vaginal examination and other stimulating activities should be avoided. You want to put the woman to side lying position and you monitor the amount of bleeding. Like I told you, it's going to be bleeding from the uterus, and that's a major organ that is muscular and can cause more bleeding. So vaginal examinations are contraindicated if the client is suspected of having or has a known placenta previous. So if you had it before with your other child, and this one you are at risk for it, so they want to stop vaginal examinations as much as possible. Placenta abruptio. This one is premature separation of placenta from the uterine wall after the 20th week of gestation and before the fetus is delivered. So after 20 weeks of pregnancy, the placenta just come out. It separates itself. So looking at it here, this is the placenta, and this is the uterine wall that is supposed to be attached. So the uterus is oval shaped. It's supposed to be attached. Now it has detached. Here, you see here, it just came off. That's detached. So this is the attachment. And that one too, we have 3 types. We have the partial separation, the one with concealed hemorrhage. It keeps the blood within the cavity of the hole that is created. And then this one, we have the partial hemorrhage, apparent hemorrhaging. So you can see this one is allowing the blood to come all the way out here, and then complete separation. Completely, it comes off. So everybody is free to go. So when you assess the patient, the bleeding here is dark red. Placenta previa, the bleeding was bright red. Placenta abruptio, bleeding is dark red. Is both vaginal bleeding. Bright red is placenta previa, dark red is placenta abruptio, detachment, complete detachment. So in this case too, vaginal exam is also contraindicated. You want to stop that as much as possible. And now let me clean my board. Okay, so there'll be uterine pain or tenderness, uterine rigidity. The uterus will become rigid, firm. You want to monitor maternal signs and fetal heart rate. Of course, shock is a problem because there'll be bleeding. Hypovolemic shock because there'll be loss of fluid. So loss of fluid will cause hypovolemic shock. Then you want to prepare them for delivery if the baby is healthy. So if the baby is healthy, you want to prepare for vaginal delivery. If the baby is in distress At this point, because the placenta is detached, baby is not getting oxygen, baby is not getting this, and the baby goes into distress. You cannot wait to do vaginal delivery. You have to do emergency C-section, so you prepare the patient. It is the nurse's role to help in preparation, pre-operative. So you need to know the difference between the previa and the abruptio. So in previa, there is painless. Placenta previa, there's painless, bright red bleeding, and the uterus is soft, it's relaxed, and it's not tender. But in abruptio, there is dark red bleeding. The uterus is painful or tender. There is pain or tenderness, and the uterus is rigid, it's firm. In the placenta abruptio, the uterus is rigid. I think I have maybe the last aspect of this, and that one is pyelonephritis. Remember, pyelonephritis is a urinary tract disorder. Inflammation is a bacterial infection that occurs upward from the bladder through the blood vessels and lymphatics in the renal pelvis. Remember when I showed you the Bowman capsule and all those things, the wings of it, the cervix of it. Pyelonephritis is inflammation of the renal pelvis. So you want the mother to do follow-up, frequent follow-up of untreated uterine UTI. So the woman keeps getting UTIs and it's not being treated, the infections start traveling up. So pyelonephritis is a problem in pregnancy as well. We have sexually transmitted infections, like which I have mentioned this, and it was still in the TOUCH acronym. So the STDs that we have: chlamydia, syphilis, gonorrhea. We have the human papilloma virus. This is the one they do the cervical screening for. Cervical screening for. Trichomoniasis. We have bacterial vaginosis and bacterial candidiasis. I'm not going to go into that because I did speak about them when I spoke about the disease or the assessment that will be done, the disease conditions that these are now the risk conditions, but I spoke about disease conditions in pregnancies. Tuberculosis is also another problem. Pregnant women can have tuberculosis. So remember, if a patient is tuberculosis positive and has family members, the family members, they put them on isoniazid for I think 6 to 9 months. Yes, they put them on isoniazid. They take medication as well. They assume they were exposed. If you come in and you are tested and you are positive for tuberculosis, they follow up, and then the screening all show that it is true, it's confirmed, and you are living in the house with 3 people. They put them on isoniazid for prophylactics. It's prophylaxis. That doesn't mean they have it, but the family members take isoniazid as well. So let's talk about tuberculosis. It's a highly communicable disease caused by Mycobacterium tuberculosis, transmitted by the airborne route. So multi-resistant drug strain of tuberculosis can result from improper compliance, non-compliance with treatment. It can always go and come back if the person is not compliant with their treatment regimen. So non-compliant is a big issue with that. Transmission, like we know, in the baby, in the pregnant woman, we're talking about tuberculosis with pregnancy. So transmission will be transplacental. So through the placenta, it is rare. Transmission is rare. It's not so obvious to have the baby in the stomach get the tuberculosis. It doesn't cross the placenta. It's rare. It doesn't mean it doesn't happen, but it's rare. It's scarce. Transmission can occur during birth through aspiration of infected amniotic fluid. The amniotic fluid is infected with the virus or the bacteria, so it's possible to have that there more than through the placenta. So when they're doing the delivery, it's possible if the baby accidentally ingests the amniotic fluid. So newborn can become infected from contact with infected individuals. So if mommy has it and baby is born and baby is with mommy all this while, then the baby is at risk. So you want to separate mommy and baby, but as much as possible, you also want to have the mother wear a mask. You also want to have the mother wear a mask. A surgical mask is okay after delivery to be able to hold the baby. That's bonding. You want to encourage bonding, but mommy has to be able to wear a mask. But after that, after the delivery, you try to separate them so that you don't get the baby infected. Risk to the mother. What is the risk for this to the mother? There's active disease during pregnancy, and this has been associated with an increase in hypertensive disorder of pregnancy. So for women who are at risk for all these diseases, they are at risk for tuberculosis as well. Their immunity is affected. Remember, pregnancy in general will lower your immunity. So X-ray should be done only after 20 weeks of pregnancy. So under 20 weeks, the pregnant woman is not supposed to do X-rays. But even before they do the X-ray, they have to cover the abdomen with a lead shield. They have to use a lead to cover the pregnant woman's abdomen to have an X-ray done. So tuberculosis skin testing is safe during pregnancy. However, the doctor may want to delay it until the woman have the baby. If not, PPD is safe during pregnancy. It doesn't go into your body, it's just on top of your skin, and it is safe. Now let's look at the pregnant client with tuberculosis. Pregnant client, you want to administer isoniazid, parazinamide, and rifampin in daily for 9 months. So if you are pregnant and you have it, you take these 3 medications for 9 months as the doctor will prescribe. Ethambutol is added if medication resistance is likely. Ethambutol is another medication for tuberculosis. It is added when needed. Pyridoxine should be administered with isoniazid to the pregnant client to prevent fetal neurotoxicity caused by isoniazid. So the side effect of isoniazid has neurotoxicity. It can affect the baby's nervous system. So because of that, you give it with pyridoxine, which will help to prevent the baby's nervous system from being infected or from becoming toxic. So you also want to promote breastfeeding if the client is non-infectious. We know the first 3 weeks of the disease is infectious. And after treatment, after the 9 months or after 12 months, if the lady or the patient that is the positive one, that was positive, has to have 3 negative sputum cultures to be confirmed cleared of the disease. They have to do 3 negative sputum cultures to be considered clear or free from tuberculosis. This is not only pregnancy, but that is the standard for managing tuberculosis patient. So with the newborn, the management is focused on preventing and treating the underlying infections. That's what you're focusing on. The skin testing is performed on the newborn at birth. Skin testing, that's the PPD. You implant it at birth. And the newborn may be placed on isoniazid therapy. So remember, they said you give the isoniazid with pyridoxine to prevent neurotoxicity. So the newborn can take it after the baby is born. But when the baby is in the stomach, you want to be mindful. The skin test is repeated in 3 to 4 months, and isoniazid may be stopped if the skin testing remains negative in 3 to 4 months. That's the repeat. If the skin test result is positive, the newborn should receive isoniazid for at least 6 months as prescribed. If mother's sputum is free of organism, the newborn does not need to be isolated from the mother while in the hospital. So if the mother's infectious stage is over and the mother is no longer infectious, even though the mother is still positive, they would let the baby isolate. But if the mother is no longer infectious, the baby can stay with the mother whilst in the hospital. So urinary tract infections, acute cystitis, and pyelonephritis that I have spoken about, and this is our last portion. This is in urinary tract infections, as I have spoken about. Cystitis is UTI. Now, obesity in pregnancy, this is another problem. And obesity can induce early delivery. The whole United States, I would say we are all obese. I'm part of it. Obesity in pregnancy places the client at risk for severe complications during the pregnancy, and it includes gestational diabetes, gestational hypertension, preeclampsia, venous thromboembolism, and increased need for C-section. So patients that have gestational obesity, they are at risk for C-section. They are at risk for C-section, so they are candidates. Predisposed factors. Any question? Anybody has a question? Are we tired? Are we sleeping? Because I'm ending the class now. Hello? Any question?
No question. I don't have no question.
Are we sure we are understanding the lecture? Because I know I'm rushing it. Because I don't want to come back to it. I don't want to waste too much time on it. Did we understand? If you want to type your question in the chat room too, it's fine with me. Just type it, we'll talk about it. How are we doing with our work, our assignment? I gave you 2 assignments this week. How are we doing with that? 2 assignments, week 3 and week 4. And I think some people got, is it 7 and 8 or so? And I did receive some people's own. I'll make time and sit on it this weekend, so. Okay. Patience, any question? I didn't hear from you today.
You
Patience.
said 7/75?
Huh?
7/75.
What's that?
Oh, I thought you said some people get 7 and 8.
Oh no, I'm talking about the weeks. I know you are talking about the maths, right? No,